Hi, good morning, everyone. I'm Serene, one of the scholarship officers at Healthcare Scholarships and Talent. To start off, a warm welcome to the Healthcare Scholarships Virtual Experience 2021. Throughout the 2 weeks of virtual events, ending on 3rd March 2021, you'll get opportunities to participate and interact with scholar ambassadors, scholarship officers, university partners, and professional representatives from various public healthcare institutions. Do note that we have an ongoing leaderboard and game section for participants to win attractive prizes, such as Universal Studios Singapore one-day pass, Disney Plus subscription, Grab food vouchers, and many more. There are many ways to earn points, such as attending programs, asking questions, and playing with our daily games. Welcome to Withstanding the Test of Time, Rethinking Population Aging. Singapore is facing a silver tsunami brought on by an aging population. This places tremendous stress on our public healthcare resources. See how National Healthcare Group's healthcare professionals leverage on innovation and technology for better health outcomes. Before we begin, if you have any questions for our speakers, please feel free to type in your questions into the Q&A function. If you'd like to direct a question to a specific speaker, please kindly indicate it in your question. Lastly, if you have any questions that you're interested in being answered, please upvote the questions. Do note that the question with the highest upvotes will receive a $10 Grab food voucher. So do start posting your questions and upvote your favorite questions. So I would like to welcome Ms. Wendy. Ms. Wendy, please.
Hi everyone. I'm Wendy, a nurse manager from Tan Tock Seng Hospital. Thank you for joining me on this Saturday morning. So as we know, Singapore is facing with a huge wave of aging population. So today I'm going to share with you on how we leverage on technology and innovation to relieve the stress that aging has brought on healthcare and also improve on patient safety. It is estimated that by 2030, 1 in 4 will be aged over 65, and this will rise to almost 1 in 2 by 2050. As we age, we experience changes that can encompass physical, psychological, and social. Our bones tend to shrink in size and density, weakening them and making them susceptible to fractures. Muscles generally lose strength, endurance, stability, and balance. So with this, we are more prone to falls. Inpatient falls are common, yet complex challenges that influence hospital care, particularly in elderly patients. So actually more than 1/3 of inpatient falls results in injuries such as fractures and head traumas, resulting in heavy burdens in terms of medical, financial, and social outcomes. Falls that do not result in injury may consequently cause distress and anxiety to patients, their next of kin, and healthcare team. It may lead to a restriction of further activities, further losses of strength, and lastly, independence. So traditional solutions that we have tried out, such as a bed exit sensor mats or motion detectors, are too inaccurate and are cumbersome to deploy with no automations or smart features. So nurses usually suffers from alarm fatigue. So Tan Tock Seng Nursing started collaborating with a local engineering company to explore the use of thermal cameras for fall surveillance. So our innovative journey starts from here. Our key system design consideration. So we wanted something that does not intrude on patients' privacy and yet at the same time increases productivity and efficiency. Provides 24 hours round-the-clock monitoring, gives the healthcare team sufficient time to respond, and a playback feature for post-incident analysis and future learning. So we studied 80 high-risk patients with more than 12,000 hours of data used for machine learning. The system trained is able to detect objects and recognize a series of movements resulting in bed exit. With that, an artificial intelligence system is then built to recognize and predict such activities, and the system is integrated with alarms and front-end graphic user interface for system validation. So from our studies, the key finding shows that it takes an average of 15 seconds for the first limb out of bed to move to a sitting position. So an alarm is activated within this 15-second time frame, allowing the nurse to intervene before the patient gets into a standing position. So the system shows that it has a high accuracy of 99.7% sensitivity and 100% specificity. So we named the system Presage, a bed exit prediction and prevention system. It is a combination of thermal image processing with proprietary AI predictive engine and data analytics. The key feature of Presage has fulfilled our initial key system design consideration. It is privacy preserved as no distinguishable feature can be identified. It provides continuous monitoring as the property of thermal camera makes it possible to see even in the dark, and a playback feature for post-incident analysis and learning. This is how the Presage camera looks like. It is installed in the patient's room for falls surveillance. So I'll now show you how it works. When the system is turned on, the Presage provides continuous monitoring. When a bed exit is predicted, an audio-visual alarm will be triggered and the nurse will intervene. The alarm will be automatically deactivated when the nurse intervenes. So it's actually a hands-free solution. And when the patient is back to bed, the system will automatically start active monitoring. So you don't have to press any button. We are actually moving from a detection-based falls surveillance to a prediction-based to prevent falls from occurring. This is the end of my presentation. Thank you.
Hi, Wendy. Thank you so
Hi.
much for your sharing. We actually do have quite a number of questions in our Q&A section. Thank you so much for posting your questions, guys. So I'll just start off with the first question because, Wendy, we do note that you are a nurse. So the first question is, can you elaborate on what does a career in nursing look like when you are in your 40s and 50s? Will I be working in a ward until I retire?
Okay, so it's not really pertaining to the presentation.
No.
It's actually it depends on what you want. Yeah, if you prefer to be, if you are more a clinical person and you prefer to be in the wards, working with the nurses, with the patients, then I think you'll be more suitable in the ward. And it depends on which career type you want, more admin or you want more quality based. Yeah, so it actually depends on what you want actually. And there are actually many career paths in nursing, so it really depends on which path you want to take.
Thank you, Miss Wendy.
Yeah.
We actually do have one other question, so it's not really pertaining to your presentation, but it's because we do note that the program for today is regarding the aging population. So this question is, how will our aging population affect the demand for healthcare workers in the future?
Yeah, definitely with the increase of as in the rise in the aging population, it will cause tremendous stress on healthcare. So actually we are looking at ways on how we can improve productivities and like using technologies, leveraging on technologies and innovation, so we can improve on a patient's experience, patient safety wise, and also not tax so much on the nurses part.
Thank you so much, Ms. Wendy. We'll proceed on to Mr. Johnson. Mr. Johnson will be covering on the session on transition between acute and primary care. Mr. Johnson, please.
Hi everyone, very good morning to you all. So my name is Johnson. So I'm actually a nurse from Tan Tock Seng Hospital Community Health Team. So thank you for allowing me to just share between the transition between acute and primary care. Okay, so just an overview. So Tan Tock Seng Hospital actually looks after the central region. So this is the rough demographic of the population. So we actually look after one of the largest catchment area, about 1.4 million residents. Okay, so the community health team, CHD in short, comprises of a multidisciplinary team. So there's actually doctors, nurses, allied health professionals ranging from physiotherapists, occupational therapists, speech therapists, dietitian, all the way to medical social worker. We have pharmacists, health coaches, and ops supporting the team. So you've been hearing me saying central zone. So you might be curious, where do we actually cover? So actually subdivided into 7 subzones. So they are mainly Ang Mo Kio, Serangoon, Hougang, Bishan, Toa Payoh, Geylang, Novena, Kallang, and Rochor. So this is actually our coverage area. And also in CHD, we believe in a multidisciplinary leadership structure, which means we actually have team leads that actually governs the different subzones. And our team leads are actually might not be a nurse or might not even be a doctor. They might be other allied health professionals. Okay, so what's the aim of CHD? So we're actually looking at moving away from individual professional services, meaning not just a nurse catered care. We're actually looking at multidisciplinary approach. So which means a particular case, we actually have a multi-team coming on board to actually give their suggestions and actually develop a more patient holistic care to actually care for this patient. And on top of that, we also look at building relationships and also working with local partners. So partners in this sense means the community partners in the community. So they can be partners like AWA or Touch or Home Nursing Foundation, which are more commonly heard of, and actually work with them to actually ensure the care coordination is established and also helping the individuals to actually age in place. Okay, so these are some scopes of practice that we cover. So basically, we actually look at the medical assessment. We actually do medical assessment at patient's house. We actually care for them in terms of checking, stabilizing them post-discharge, ensuring that they are actually properly transit back home. On top of that, we actually do health education. So we don't only target the sick and the frail. We also look at patients who are pre-frail, the well, and do functional assessment, mainly done by the health coaches, to actually see how else we can actually help keep them healthy in the community. Health coaching is one of the areas we actually focus a lot on, done by the health coaches, mainly to focus on group strengthening exercises as one of the example. We go down to senior activity centers located in the neighborhood and actually conduct activities that can actually enrich them and also train them and keep them healthy. So health check is something we commonly do. So nurses can either do it at the post, if not, we do home visit to actually check clients' condition at home. Blood pressure and also blood sugar is one of the many things that we check for. And we actually will see patients at home and so see how we can actually help look after them post-discharge and make sure that there are no complications. Next will be medication advice. So understand that a lot of time when patient get discharged, they actually has a lot of medications. So we will actually go to the house and see how we can ensure that the medications are actually taken properly. This could actually help reduce the chance of them getting readmitted. And lastly, we actually work a lot with our community, with our therapists to actually do joint visits to actually see clients at home. So usually visits are not particularly done by nurses alone. If a therapist thinks that there's a need to join along, they'll actually come by and actually we'll see how we can optimize care at home. Like we will do visits with occupational therapists to ensure that the patient is actually free from fall at home and see how if there's any need for any home modification. And we actually do visits with therapists, with dietitian to actually see how we can address some concerns they have at home. So on top of all this primary role, nurses in the community health team also engage the partners with the 4 various illustration of engagement. So we actually do partners networking. It's a time whereby we'll get together with partners and to build awareness and also to actually understand the community better because they are mainly on the ground. So they will actually know what is required or what is lacking in the various subzones. Then we can see how we as Tamoxing actually can help them. And also we actually do case discussion. So this is a multidisciplinary case discussion whereby the nurses, the doctors, and the therapists will actually sit down with the partners and we'll discuss on various those most challenging cases to see how we can help optimize the care at home. And we also do subzonal partner meeting. So subzonal partner meeting is slightly bigger, whereby the partners of the particular zone will come together, and after that they will actually share about how are things like within the zone, and they also just let us know what are some areas that we could actually help optimize, and we can see how we can help each other. And lastly, we do meet the leadership of the area, like the MPs, and see how we can actually work together to actually better care for the populations. Okay, so my next slide, basically I'll share with you a patient journey that I've actually looked after. So my client is called Mr. Tan SB. He's a 77 years old Chinese male, single. He stays alone. He's actually known to touch home care. So his medical condition wise, he actually has Parkinson's disease with low blood pressure. So each time when he changed a position, his blood pressure will actually drop. And also he actually has problems swallowing and also have eyes problem. So basically on 5th of June, he actually was found fainted at home. Then after that, neighbors actually called the ambulance and she got him to be sent to the hospital. Then on the same day, due to his communication error, he couldn't communicate. That's why the doctors actually had to get in touch with Nurse Koo, the nurse from Touch Community Care, to actually know more about the patient's condition at home. Then on 17th of June, patient is actually very keen to get discharged. He treasures his independence a lot, but due to some care needs, due to his low blood pressure, we're actually unable to do so. So we actually liaise with also the inpatient medical team, actually liaise with the Nurse Koo to see how we can actually optimize care at home. The 5th of June, he was actually referred to my team. Then on 30th of June, he was actually discharged. Then subsequently, we actually contacted Nurse Koo to see how we can actually do a joint visit to actually see how are things like at home. Okay, so for this instance, Mr. Tan at this point actually planned for nursing home placement due to the lack of caregiver and due to his medical condition. So we actually did a joint visit by myself, my occupational therapist, and my social worker, and not forgetting Nurse Koo. So the purpose of our visit is to see how he can actually optimize his care at home, ensure that he's still staying in a safe environment, whereby his daily well-being is still taken care of, and he will not have recurrent fainting episodes. And also to see how we can actually keep his care more optimized, to actually keep him in the community instead of sending him to nursing home. So ongoing home visit was done. A caregiver training was done by the therapist to teach the neighbor. So in this sense, Mr. Tan was lucky. He has a very good neighbor who is actually keen to take up a caregiver role to actually help care for him at home. But we need to empower this caregiver. We need to train him. We need to make sure that he's able to look after Mr. Tan at home. So together with therapists, we actually did a caregiver training back in home, which is in the home setting of the client. So he's actually able to understand the whole care and how to actually help him when he's in bed and out of bed. Subsequently, when things are more stable, that's where we actually start addressing more issues. So we actually got in a speech therapist to actually check on Mr. Tan at home to see how his swallowing can be helped. If let's say a change in modified diet might be required, and that's when we actually work with Touch to actually send him modified diets to actually keep him healthy at home. So lastly, our speech therapist did a home visit to actually see Mr. Tan at home. So to sum up the story, so Mr. Tan is still currently in the community. So the initial plan of sending him to nursing home was actually cancelled because he's actually well supported with the community partners, and at the same time, the caregiver feel empowered to care for Mr. Tan and is actually very comfortable doing so. So these are one of the examples that we have in terms of how we actually help the community and help transit patients from hospital back to home. Okay, so last slide, I would like to just share with you my personal reflections. So as you can see, I actually illustrated the reflection with a stock market. So basically being a nurse in the community health team has its ups and downs. So prior to being a comm nurse, I was actually a ward nurse. I was in the ward for about 2 years. Then after that, I got transferred out to the community. So it's very challenging in the start because we actually face clients at home. We actually see them on our own. So a lot of times it's just us and the clients where we do discharge planning. But nevertheless, we actually have a team behind us who is always supporting us when we're at the patient's house. So it's actually very nice to actually see patients at their own home because usually family trusts you. That's why they actually let you into their house. And that's when we actually discover why a certain condition kept repeating. And that's how we actually help optimize care. And also the community has evolved a lot from last time, just depending on hospital and all the care. Now community partners, community providers are more keen to actually take on the role to actually help support the people in their region and also help care for them. So with these, it's very fulfilling to actually help patients to actually get back home and work with partners. So at the same time, we also want to empower them to make sure they are actually able to care for the patients in their region. So to prevent the silver tsunami from coming, or rather to act on it, we actually can work together and not only just solely depending on resources in the hospital. Yeah, thank you so much.
Thank you, Johnson, for your insightful sharing. We actually do have quite a number of questions for you. So to participants, attendees, do note to upvote your questions because we do have quite a lot of questions coming out. Upvote the questions that you would like to see answered. So for the first question for Johnson regarding community healthcare, so the question is, if I stay in Toa Payoh, but most or all of my SOC follow-ups are at KTPH, but I was last awarded at TTSH for my last admission, would I be assigned for Com Health Care under TTSH or KTPH?
Okay, so regarding that question wise, so Toa Payoh is actually one of the coverage area. So let's say you're looking at a community nurse coming on board to actually look at the care coordination, mainly will be done by Tan Tock Seng. However, if let's say there's a need for us to communicate with Khoo Teck Puat, we actually do so because we're actually in the same cluster. So moving on, when there's a change in the documentation system, you'll be able to see on the other side what the specialists actually plan for you. So the care in a way will not be lapsed. So we actually get the various updates from Khoo Teck Puat Hospital as required to actually help optimize the care at home.
Thank you, Johnson. The next question is, do you require a minimum number of years of nursing experience to join the community healthcare team, or is this open to new graduates as well?
Okay, so at the moment now, majority of nurses here actually comes from ward background because it's actually quite important for you to have the bedside clinical and basically to understand how a transition like from hospital back to home. So by being the ward, it actually given you an added advantage to actually understand the patient stay when they're actually in the ward. So does it open to new graduate? I believe with the involvement of community health team and us understanding the community better, we're actually more open to take new graduates because we'll be able to train them better. And we actually know what are some areas we're actually able to help give the new graduates in terms of experience because they might be lacking the ward experience to let them see cases. And we also might be looking at transition between hospital and ward. So not mainly so much of just being the community itself. Because a lot of us, sometimes we also need to get updated information from our inpatient colleagues. So we do with specialist nurses to actually get updated trend of the current changes in nursing.
Thank you, Johnson. I would just also like to add a little bit more on our community nursing scholarship, because we actually do have a community nursing scholarship for students to pursue a degree in nursing, and after which they'll be posted to one of the community care settings. So actually we do accept fresh grads, and they do actually go into the community, but definitely with some assistance and some training from their seniors. Yeah. So the next question for Johnson, what kind of skills are favorable or needed to better prepare in the face of an evolving healthcare scene with a rise in aging population?
So in terms of skills wise, a lot of time in community nursing, actually a lot of plans actually done by nurses. So we're moving away from basically doctors deriving with the medical plans. So nurses along with other allied health can actually develop patient-centric care plan. So a lot of times medical problem might not be the main issue. A lot of clients actually do come back hospital due to social needs because maybe they are not in very good relationship with their children, or they're not even married and they don't have anyone to look after them. So we are actually working with partners to actually see how we can actually support them, make them feel that they are actually supported in the community. So in terms of skill sets wise, actually you need to have a skill of everything. You need to understand a bit about therapies, because when you go to the patient's house, the family actually kind of depends on you a lot to actually care for these clients.
Thank you, Johnson. I have one last question for you. So the last question is, would entering into a sector specialized in aging population be more favorable in the future? I do believe this is probably geared more towards a fresh grad looking at coming into the healthcare setting and trying to go into a specialization, if I'm not wrong.
Yes and no, because if you're asking me, because for the community wise, actually it comprises of both elderly and also it comprises of the well and the pre-frail. So actually looking at a lot of prevention, aiming at the upper stream of the river to ensure that before they become frail, we actually help care for them, and also preventing them from requiring more acute hospitalization kind of care. So actually looking at a lot of empower the individual to care for themselves. So if let's say you to dive straight into the elder population, yes, you can actually help the elderly, but again, you might require some form of experience to deal with all those who are well, so you won't keep coming daunting on the unwell and the sick and the frail. Yeah.
Thank you so much, Johnson. Thank you for your sharing too. Next, I would like to invite Ms. Stephanie Ong. She will be sharing on Kampung Admiralty and Admiralty Medical Center. Ms. Stephanie, please.
Hi, good afternoon, everyone. I'm Stephanie from Admiralty Medical Center, Operations Department. I'll be bringing you through the overview of Kampung Admiralty, AdMC, as well as some collaborations and partnerships that are in place. After which, my colleagues from Diabetes Center and Eye Center will be sharing with you on how technology and innovation is adapted in healthcare. Without further ado, let me introduce you to Kampung Admiralty, where AdMC is located. It is conceived as a modern kampong as it integrates a wide range of residential, healthcare, communal, commercial, and retail facilities all under one roof. The design facilitates interaction between residents and members of public across different age groups. For instance, the community plaza as seen on the top left-hand corner is a bustling platform where events are held. Residents and members of public bond together over activities. AdMC is located at levels 3 and 4 of Kampung Admiralty. We are designed to be integrated with Kampung Admiralty, which is why it is built around a courtyard, and you can see the residential flats. It is also designed to be an energy efficient, cost-effective, and green environment. It's a one-stop medical center for outpatient clinic consult, day surgery, rehabilitation, and diagnostic services. Our services are run by clinical departments from Khoo Teck Puat Hospital, and we commenced operations in July 2017. Here are our medical facilities and services offered in AdMC. We provide transdisciplinary care and co-management with GPs, such as complex diabetes cases. We provide surgical care for focused medical conditions of low complexity to reduce the referrals and to acute care hospitals. Some procedures include cataract surgery, carpal tunnel, and endoscopies. For GPs, we also offer direct access to allied health services. AdMC provides education and training for primary health providers, public, and patients. Similar to acute hospitals, majority of patients are seen on an appointment basis with a referral by polyclinic or GP. When patients' conditions have stabilized, we also work in conjunction with GPs and polyclinics for patients to continue reviews with them. AdMC aims to provide hassle-free, person-centered specialist care in a convenient community setting and keep patients healthy in collaboration with our partners. Being a medical center, we will also reach out to residents in the north to conduct health and wellness talks and educational workshops to promote well-being and encourage a healthy lifestyle. For instance, AdMC supports MOH Project Silver Screen, whereby its aim is to bring functional screening to seniors in the community as part of efforts in preventive health to help seniors age well in place. AdMC supports in both vision and hearing screening. Also, we have a partnership with NTUC Health Active Aging Hub located in KA Level 6 to provide community and home eye screening service. This provides access to eye care for elderly and homebound residents in the community. Also, it reduces referrals to hospitals while remaining cost-effective using existing resources. We also form a partnership with Sport SG to bring healthy living to residents in the north through Active Health Lab at AdMC. It is the first of its kind to be housed within a community medical facility. We use a two-way recommendations process, such as from Active Health recommending patients to doctors for medical assessment if required, and from our clinicians recommending patients to Active Health, allowing patients to transit from medical care to self-care. They provide patients access to fitness assessments, team group classes and workshops, some even customized to patients of Yishun Health Campus to empower them to stay healthy. To illustrate more on our collaboration with primary care and how technology and innovation is adapted in healthcare, we will be sharing with you through a three-part video. Mel and Citra will be taking you through their programs on diabetes shared care and group education program, and Surya will be taking you through the application called Mata. Thank you.
Hi, I'm Melly. I'm from AdMC Diabetes Clinic. I'm here to share with you about our DM Shared Care program. So this is a program where our DM specialists collaborate with GPs to co-manage with patients with a stable DM condition. This is a patient-central care pathway that ensures patients with DM receive timely care and access to resources to help to manage their acute and chronic health needs. So the key enablers are patient-central care pathway, clinical leadership, also support from our pharmacy, information and knowledge sharing, and also sustainable pricing model for the GPs and patients. So the key elements of DM shared care pilots are joint provisionals of clinical service of DM patients by specialists and GPs, and also share responsibility for patients' care. GPs can also help to manage acute and subacute and primary care issues. Medication dispensing model to level cost gradients and monitoring and exchange patient clinical information. GPs can also access to specialists via title text or email. Professional discussions on patients' care, sharing of skills and knowledge between specialists and GPs. So currently, our first pilot collaboration is with Frontier Health Groups that include 11 GPs clinic and also 1 family medical center. So once the suitable patient is identified, our partnership office will proceed with the workflow. Thank you.
Hi, good morning. My name is Chitra and I'm the Program Coordinator in Admiralty Medical Center. Today we are going to talk about our group education programs in Diabetes Center. And this education program aims to empower our patients to cope with their diabetes. So what are the goals of our patient education in management of diabetes? This empowers our patients to change their lifestyle, maintain an adequate diet and physical activity, manage their condition better and medications also. It also identifies and troubleshoot problems related to their condition. So here are the programs in our diabetes center. We have the Basic Skills for Life program, Ramadan edition, Renal, the Diabetes Education Program Lifestyle, and also Diabetes Education Program for Insulin. So for our Skills for Life is a basic level, and this basic course is designed for people with diabetes to know more about their own conditions and also to learn how to manage it effectively. We encourage all our patients or even their caregivers or even friends to join us in our SFL program, be it whether they are newly diagnosed or even those having long-standing diabetes. For this program, we have no inclusion or exclusion criteria. For our Skills for Life Ramadan edition, this special edition is only held once a year during the month of Ramadan. So it's a fasting month focused education program for our Muslim patients. It is to empower our Muslim patients to fast safely during Ramadan, and the inclusion criteria is just those who have the intention to fast for the month of Ramadan. So in 2014, we have an article about our group education program, which is the Ramadan edition. That shows our D&E Mariana giving the education program to our patients. The next program we have is the Skills for Life Renal, or looking after your kidneys. This one is also a basic level of program. It is for those patients who have early signs, symptoms of diabetes kidney disease, and microalbuminuria and proteinuria of certain creatinine level, and those who have interest in kidney disease prevention. The next program is the Diabetes Education Program Lifestyle, or we call it DEP Lifestyle. This is a slightly advanced level. So this course is more intensive and it is designed for people with diabetes to understand how lifestyle affects them. It empowers our patients to make adjustments to their lifestyle to improve their own condition. So it's over 2 half days, or consider 8 hours lah. Our target audience is those who are motivated, those who have the basic knowledge of diabetes, and those who have completed the basic skills for life program. So for our DEP lifestyle, so all these photos are taken before COVID-19. So we have the supermarket tour, learning food care from our podiatrists, and knowing more about their own DM medications. We have activities for them also. And we do exercises with a physiotherapist, and also do group discussion about how to cope well with your disease. And this is our current DEP lifestyle post-COVID, with all the safety distancing measures. And our last program we have is the DEP insulin. So this is more advanced level, and this allows patients to have a better understanding on their own insulin therapy. It will take them on a higher level of learning on how to adjust their insulin dose to better suit their lifestyle, be it diet, physical activity, during stress, illness, or during travel. The goal of this program is to attain good glycemic control without hyper or hypoglycemia, and not compromising on a flexible lifestyle for our insulin-dependent patients. So what are the requirements for this course? This course is targeted for type 1 patients and type 2 patients who are insulin dependent. They must be willing to learn, able to handle math. They must be a bit more tech savvy, and also willing to share and participate with other participants of the program. Even though all these requirements we set for our patients, but sometimes it may not required, as we have a good team who will do their best to care for our patients. Thank you.
Good day, everyone. I'm Surya from the Operations Department supporting the Eye Clinic. At the Eye Clinic, we come up with various technologies that can be used outside of the hospital for ease of early detection and monitoring of certain eye conditions amongst our seniors. As such, today I'm pleased to share with you on one of our Eye Clinic innovation known as Macular Amster Testing Application, or in short, MATA. MATA is a smart eye health monitoring application that can be easily used at the comfort of your own home. So let me share the slides with you. The objective of this project is to design a user-friendly smartphone app that would empower patients to perform central visual field screening at home. The age-related macular degeneration, or AMD in short, and diabetic maculopathy are common eye conditions that affect the central retina. Figure 1 shows how an image would appear for those with normal vision. Figure 2 shows how the image would appear for patients with visual field defect. So how do our seniors test for or monitor symptoms of AMD? They would use a paper-based Amster grid chart as seen in figure 1 here. The patient would need to cover one of their eye and focus on the center dot as seen in this figure. They would subsequently repeat for the other eye. If the grid line appears distorted as seen in figure 2, then this may indicate symptoms of macular degeneration. As is, or the current state, patients perform home monitoring with the paper Amster chart. We found that this method may not be ideal or sustainable. This could lead to inaccuracy due to the variable distancing. 2B, or the future state, we thought of an innovative smartphone app that is designed to replace the paper chart for self-monitoring of macular function. The Macular Amster Testing Application, MATA, was developed by Yishun Health Ophthalmology and Visual Sciences Department in collaboration with IHES and Operations Department. It is an innovative smart health monitoring system that is designed to educate AMD patients as well as facilitate early diagnosis of visual abnormalities. The app is also suitable as an eye screening tool for healthy people aged 50 and above and patients with diabetes or age-related macular degeneration. As such, MATA trains and enables our seniors to use technology to continuously do self-eye monitoring with Amster e-chart on their smart devices. So how does it work? So you simply need to download the MATA application on your smart devices. Let me show you a quick demo of how MATA works. So after downloading the app, you have to click Start Test, and you'll be testing your right eye by covering your left eye. If you don't see any distortion, you click No. Then you follow on with your other eye. You cover your right eye to test your left eye. If you see distortion, click Yes, and then circle the distorted area, and then save the image. You can see how fast this whole MATA assessment was done. This is less than 1 minute. So MATA improves patient compliance and test accuracy. For instance, the user interface is intuitive as the eye tracking system ensures that the user holds the phone at the correct testing distance with the correct eye covered for test accuracy. This is not possible for the paper-based Amster chart. There is also a test guide module with video demonstration that shows how to use the MATA application. It's a step-by-step guide that educates patients on how to use the MATA application. Next, the data capturing and measurement system allows users to mark out the distorted area seen on the Amster e-chart, as you saw in the demo earlier. And the screenshot can be saved directly into the user's photo album as a digital image for health record, archival, or specialist evaluation via telehealth. There is also a reminder notification system to improve patients' compliance to do regular eye testing in a timely manner. So if you set the date as 7, the days as 7, then after every 7 days, there will be reminders sent to you to conduct your MATA test. There's also a patient education module with links to AMD brochures and reliable educational website. It also provides medical advice for abnormal test results. And if you obtain some abnormal test results, users will be prompted to seek medical attention and provide them with information on healthcare providers. There are several benefits to MATA. Firstly, it employs the patients to perform self-monitoring at the comfort of their own home. There is also a higher compliance to perform Amster testing on a regular basis due to the reminder notification. Unlike paper-based Amster testing, the MATA has better accuracy, and it is a useful tool to use to maintain social distancing where patients are only required to come to clinic when necessary or abnormality is detected. MATA indeed leverage on technology to enable seniors to perform self-monitoring. This innovative technology was showcased at AdMC to PM Lee during the grand opening of Kampung Admiralty. This is indeed a technology that helps our seniors in their regular eye care monitoring. MATA is easily accessible. You can download MATA on Google Play Store or App Store, and you can test it out how it works. So that's the end of my sharing. Thank you, and thanks for your time.
Hi, Stephanie. Thank you so much for the presentation and the videos that you have shared with us. We do have quite a number of questions for you regarding your sharing. So the first question is, are there any sort of programs similar to that of MATA that is targeted towards other eye conditions such as glaucoma?
Currently, we do not have other eye applications, but the team is constantly reviewing for more innovation, more applications to be developed to support our patients.
Thank you, Stephanie. The next question will be, what is the nursing team profile like for the various AdMC clinics? So for example, do you know the percentage of the number of APNs? So APNs will be advanced practice nurses, percentage of senior staff nurses, percentage of staff nurses and enrolled nurses, so on and so forth.
So AdMC is made up of a mixture, a combination of various nursing profiles. As the participant has rightly mentioned, we have enrolled nurses, registered nurses, APNs. It's a mixture really, depending on the patients in our clinics. So clinics like Diabetes Center, they have more nursing, such as APNs to support. They have joint consultation with the doctors to assist patients in consultations and guide them. Yeah. So in other areas, other clinics, we have nurse managers and enrolled nurses, registered nurses.
Thank you, Stephanie. Next question is, are there any programs that are aimed to raise awareness about the risk of diabetic retinopathy, which is one of the pre-diabetic or at risk of developing diabetes conditions?
So if patient has pre-diabetes or has diabetes, the doctor will actually follow up and recommend to the various programs that are suitable for the patients. Like earlier on, we have Skills for Life and group education programs. So these are all useful, and the doctors will choose the most effective program that's suited for the patient.
Thank you, Stephanie. I have two more questions for you. The
Mm.
second last question would be, how will the government choose to allocate resources to the various age groups in the healthcare industry?
So depending on the patient's condition, we will assist patients in providing the necessary resources, such as for, I will not be able to comment for the government, but at least for AdMC, right, and KTPH, such as for elderly or homebound patients, we have community nursing, community care team to reach out to the patients and assist them if they are unable to come out to the hospital. Then as for the tech-savvy patients, we also have teleconsultations available to provide a hassle-free experience for our patients as well.
Thank you, Stephanie. I do have one sub question for this because I actually saw
Mm.
it. I just saw it. So, do you guys have plans to expand telemedicine to cater to the elderly? Because we do note that for elderly patients, they actually do struggle quite a bit with technology and innovation. So, how should we roll out this kind of plans to the elderly?
So actually, telemedicine is actually in place for AdMC geriatric patients. During the COVID period, we have quite a few patients who were keen to participate in our teleconsult, and their family members are also very supportive and encouraging, assisting them to help set up the Zoom profiles and log into the Zoom teleconsult for the consultation, and it has been successful thus far.
That's great to know. The last question, Stephanie, what do you find the most fulfilling in your job?
So in operations department, it is very all-encompassing. So we are able to learn from various perspectives. We are able to tap on various medical fields expertise, nursing and allied health professions, as we work very closely with all stakeholders in the hospital. And we also learn through the feedback that patients have for us. Yeah, so overall, I guess in healthcare, it is it's a continuous learning journey.
Thank you so much, Stephanie. Thank you for your insightful sharing.
Thank you very much.
Thank you. Next up, we have Ms. Sabrina Au from Tan Tock Seng Hospital. She'll be sharing more on the Integrated Care Hub, ICH for short. Hi, Ms. Sabrina, please proceed. Hi everyone, so sorry we are experiencing a little bit of technical difficulties. Do bear with us for just a few seconds. Thank you. Our sincere apologies. Just to give us a few more minutes as we rectify this technical issue. Thank you. Hi all, it's me again. So sorry for the technical glitch that we have. We'll be proceeding on to the next segment first, and then we'll circle back to Miss Sabrina Au. So for the next section, we do have Miss Ng Hoi Ling and Yvonne Chua from Khoo Teck Puat Hospital. What they'll be sharing will be on the Yishun Health Population Health Initiatives and Programs. Miss Hoi Ling and Yvonne, please.
Hi, everyone. Thanks for having us. I'm very happy to be sharing the screen time here with Hoi Ling. We're here to share with you the work that we do up in Yishun and Sembawang. So I think early this morning, you've heard from a lot of our other presenters. So Wendy shared about leveraging on technology. Johnson shared with you about leveraging on the assets of a multidisciplinary team. And then Stephanie and my colleagues at AdMC talked to you about a patient-centered specialist center and evolving the idea of what SOC operations or specialist clinic would be. Hoi Ling and I are here to share with you how to leverage on the strength and the assets of the aging population. So if you look at the cartoon that we have put up for you, a lot of time what we've been doing is preparing to deal with crisis. And I think that has always been how the hospitals or even the medical centers have always been set up for. So we have emergency services, we have outpatient services, we have inpatient services. I think what we found along the as the population ages is there won't be enough. It is not enough to just prepare to meet people at crisis. It is important to meet people before crisis to do preventive work. But one of the main learnings that we've gathered over the years is how do we bring community into this? So if you look at the cartoon again, how do we bring people, direct people away from the cliff and back into their community? So this is just an example of the community that we have here in Yishun and Sembawang. Some of the snapshots of people that we see on a day-to-day basis. So for us, we are both the leads for the regional team here in Yishun and Sembawang. So we've basically divided Yishun and Sembawang into 6 different zones, quite similar to our central health colleagues. So each of the different zones, the teams will be very focused on the key population and the assets on the ground. So just to give you a bit of a flavor, this is a map of our one of our teams. So this is the area that they will cover. So and within these areas, we will have different community assets like your SACs, your FSCs, your social care partners, and all these partners are known and one of the key touch points for all our nurses and connectors. Like I think very similar again to our Tan Tock Seng colleagues, our teams are also multidisciplinary. So you will have a mix of nurses and our administrative staff. So over the years, we've also evolved the way we name our administrative staff. So we are known as connectors on the ground. So our connectors come from different trainings and background. So whether they are community care associates or they are center coordinators at our wellness Kampung, our executives, our health coaches, they are all part of the regional team. Really?
Hi, thank you, Yvonne. Hi, I am Hoi Ling from one of the senior nurse manager. They're working closely with Yvonne in our community nursing. We also work closely with Johnson over Tan Tock Seng side for our NHG community nursing collaboration. This slide is shown as our regional team model of care. In our regional team, as Yvonne had mentioned, we have community nurses working very closely with our connector to integrate the social and health aspect. This is the methodology that aligns with our NHG community nursing framework 2S and 2C. Later, I will explain what is 2S and what is 2C about. It also met with our Omaha system documentation. This is documentation that our community nursing team and our connector are using it to document and share our care for our residents in the community. So the first one, sensing, and the surveillance is to understand our resident and their neighborhood needs. For example, in a community like Yvonne and the team, they walk about in the community and in the neighborhood during our door knocking interview session. We understand the community asset and map with the regional team needs with the resident. And secondly is the care. Care, we provide clinical care and person-centered care plan. We give early detection and early prevention to our residents. For example, we teach them and educate them on how to monitor their own blood sugar monitoring and their own BP in the community. We promote health and create the awareness to the resident. We encourage the resident to adopt a healthy lifestyle by providing the health counseling and coaching. And we not only look into the clinical aspect, we also need to look into their social well-being and mental health aspect. The third blue color one is a coordination. With our team working on the ground, we also need to work closely with our community partner and also the healthcare services, such as the resident have missed the appointment. We need to also teach them and educate them how to coordinate the care back to the primary care and polyclinic setting. The last one, we emphasize a lot on strengthening, which is teaching, guidance, and counseling. We educate our resident, the resident and also their family member. To encourage them to do self-management, encourage the family member to be able to take care of their own loved one by themselves. By doing this, we can also help them to increase their capability, increase their knowledge to be able to continue the care in the community. We're also focusing to talk a lot on this local area coordination. This is a framework that we adopt from UK to explore on the strength, interest, and the option of the person. And we motivate the participant and motivate the person to be focusing on their strength, not only focusing on the deficit. And the last point on the number 4 is asset-based community development. We encourage our residents to participate and contribute in the community. Later, Yvonne will show the example of a case and example of the resident, how the resident that can continue to participate actively in the community. Next slide, Yvonne. This is, I think just now I was very heartening that looking into a lot of questions that are interest to join as a nurse. This is our community nursing framework. Just now I had a question asked about what are the skills that need to be equipped to be a nurse. If we want to be a community nurse, like what Johnson had mentioned, we need to be well-rounded with all the knowledge, because this is the profile of our resident in the community. As you can see, the clinical frailty scale in our Yishun Health, we are using this clinical frailty scale to to assess the frailty of our patient. For example, the CFS, we have CFS 1 to 9. As you can see, the green color one, CFS 1 to 5, 1, 2, and 3 means that they are still managing well in the community. And start from the 4, 5, 6 and above, they are become vulnerable and progressively become more frail, and it will eventually become moderate frail. Ultimately, they may reach a stage of terminally ill. Yeah. And you look at the center one is the care goal. This is the care goal of our community nursing framework. By the resident, they have continued to be able to function. They are still able to living well in the community, but there are a little portion of their risk of developing or are at the stage or early stage of chronic disease. For example, they could be diagnosed with hypertension and diabetic. So this is the group that we need to constantly provide health coaching and encourage them to continue to take care of themselves, of their own chronic disease management. We are also building relation to and collaborate with primary care to co-manage their chronic condition. Like just now, Stephanie also mentioned about AdMC. We are working very closely with the AdMC diabetic, APN, and the physician. Yeah, they continue to see them in the clinic level, but when they are out, go back to their own home, it's our community nurses to continue to educate them and strengthen them to how to continue monitor their own chronic disease at home. Yeah, when the resident come to a CFS 4, 5, 6 and above, that is where the resident become more frail, require more intensive medical care and psychosocial support. And our community nurses will provide the support eventually. Eventually, this group of resident or patient may reach a stage of palliative care or end-of-life care that is needed. So when we talk about community nursing, the nurses will require to equip with all this knowledge and the skill to be able to provide the care in the community. And we move to next slide. This is our population health improvement in the community. As you can see from here, there are 3 color bars. So traditionally, we are all focused on the problem, which is the red color bar. We focus on solving the problem when the patient or the resident reach our ED door. ED, which is our emergency department. We identify their needs and help them cope with the crisis by providing them with many services and resources in order for them to be able to cope when they go back to their community. However, we know that this is not sustainable in the long run. Therefore, we need to go upstream, which is go up to the green color bar, start point from the top. And because the objective here is we would like to identify the problem early problem solving to teach them on self-management, to encourage the resident and teach the resident to stay as independent as possible in order to be sufficient within their own community. This is what we would like to build on their strength capacity to achieve a thriving community. By doing this is still not enough. So therefore we go upstream by embedded our geographical team of community nurses and connector to identify our residents' strength and the gift. So by doing so, we can provide and also build their strength and aspiration to continue to be able to contribute in the community. We are no longer looking at just of their problem. When the problem arises, we like handling the problem. So by doing so, right, we need to go upstream and to educate them, to ask them look for their own strength and ability. And the second one, you can see the black color words at the side. This is a soul-built capacity building approach. So just as I mentioned, replaced by the embedded regional team in the community. And this onion model of care is also very important, which is when we activate the resident to self-care. And I think all of you know the onion. Yeah. And we start from the middle, which is the patient themselves. First, we educate the resident to self-manage their long-term condition with the support of their member, like family member or their social network, neighbor, or informal social network, as a first line of defense before we tapping on the formal services, which is the health, hospital, and formal services. So that's why you can see that there is an onion model to focus on, start from the patient themselves first. If the problem can address early, the community can develop to be more independent and sound-managed ecosystem. So for example, when the community nurses or even the connector identify the problem early, they can be addressed by primary care provider like GP or polyclinic with the support of the community nurses. They do not even need to come into the emergency department. Yeah. So that is the importance of identify the problem early so we can continue to keep them in the community longer. Yeah, so our ultimate aim is, you can look at the hot balloon there, is to develop a good balance of safety net services in a capable sound-managed ecosystem. So next slide, it will show you about this typical HDB block. This is our aspiration and our aim to building an ecosystem, a culture of self-help. This is the example we are at a block, Yishun block 765. Over here, we have our wellness kampung and share a pod, community nurse home, and GP over here. When our resident is not feeling well, our community nurses or connector can go up to the block to conduct a home visit to have a check on the resident. Yeah, if they need to go to the general services like GP to see them early, then we can also advise them to do it accordingly. Our ultimate aim here is to build an ecosystem, a culture of self-help, a self-managed community, and building the resilience in the community. And I think this is my last slide. Next, Yvonne will continue to talk about the dual strategy of our regional team.
Yeah, so for the regional team, which comprises of both the nurses and the connectors, we have a two-pronged approach. The first one is really looking at hotspots. So for this, we rely quite heavily on some of the data that is collected by the hospital, by the system, and also by the connectors. So the goal here is to preserve individual resilience, the capacity of the system, bend the cost curve. A lot of what we will do is touch and care. So meeting residents, getting to know those who are not doing as well as we want them to, return them to stability, and then reintegrate them back into the community. To give you a few examples, so this would be our AIP suite for the frequent admitters coming into KTPH, assertive intervention, which is a program that we have for frequent ED admitters. So we get our team to go in to understand what are the reasons that are driving, that causes residents to come back to ED. And we work with them back in their home community with their local GPs to make sure that, okay, Auntie, if you've been coming in several times, for example, for asthma attack, then we make sure that you have a good connection and you're introduced to your local GP, and the GP can support them with their management of asthma. We also have a very specialized team that's working with alcohol-related frequent admitters. We also have our health and social and health integration work, and we also look at frailty. So up in the north, we do have a pretty high percentage of residents above the age of 60. So we have a designated team that goes in and look out and build resources with our local partners to ensure that our older residents and older seniors have all the necessary support. The other bit would be very much long-term build efforts. Earlier in the earlier slide, we called it the slow build. And this, we are looking at community as a whole. So making sure that your community is strong, your community is healthy. So it's building capacity and capabilities of communities to do and create activities that they want that will be useful to help them to continue to be active. What we're hoping is to add years of healthier lives. What we are doing here is to hold, and it doesn't need to be done only by the connectors or the nurses. It can be done in conjunction with community partners and residents themselves. I think ultimately what we really want to do is democratize. So encourage all residents to create things to contribute to their local neighborhood. Decentralize a lot of the authority. I think when we first started this piece of work, residents are always asking us, do I have permission to do this? Do you have to, am I allowed to do, to bring my, to start an exercise group in the gardens? And those are things that we work with them and say, okay, if you're not confident and you want some sort of support, then we can usually link them up with the RC and we get additional support for them. This intermediate, which is a lot of this work doesn't only need to be done by staff. Again, I stress residents are capable and to do a lot of this work. We just need to create the space for them to be involved. And ultimately, when the community is stable, when the community is independent, diminish our own presence, allow them to thrive, but we don't need to sort of disappear, but we diminish our own manpower within that area. So some of these examples would be our community nursing posts, our wellness kampung, our share pop programs, our communities of care initiatives with AIC, our health and functional screenings, telehealth programs, and health coaching programs. So just again, to give you a bit of a flavor of what our regional team does on a day-to-day basis. So one care plan, a singular long-term care planning is very important for us. So that's done through, mainly by our nurses through our community health posts. There are tools that we can use to introduce to the residents. So like our telehealth kit, we do this thing called the personalized care and support planning, which is done on a yearly basis. So every year, we will do a care planning with the residents. So what would you like to focus on this year, Auntie? So Auntie could be 78 and say, this year, maybe what I want to do is make sure that I can continue to walk. I don't deteriorate. I don't need to, rely on a PMD to walk to the market. And that for us is important. So it gives the nurses very clear, information about what the resident wants to achieve in their life, and also advanced care planning. So we will introduce programs that are suitable for the residents to achieve and complete their one care plan. So if Auntie is interested to still maintain independence, then we may link her up with programs that will help her with exercise, her strengthening of her muscles, and etc. We build communities, so local area coordination, like Hoi Ling mentioned, asset-based community development, which is discover and grow a resident group. So one of the things that our connectors do very regularly here in Yishun and Sembawang is we always go around. So we will have in the back of our minds, we always know who's the leader of the local exercise group in the park, who is the group of uncles who are hiding in the void deck and maybe recycling and modifying bicycles. So these are important groups because these are where these are programs or rather activities that residents have created for themselves. And for us to work very closely with residents is to also plug into a lot of this local intel and resources. Yeah, and then finally, we also organize events. So like our mini medical school, our annual Low Hay event with our partners to update them about the latest happening in Yishun and Sembawang. Updates from residents to partners also, in which area, what are the new groups that residents have started, what are the resources they are looking for. And finally, we were able to do this just before COVID hit, which was in 2019. We did Golympics, which is a Olympics for our older residents. So let me give you just an example of a patient that went through the journey with us here. So Madam Sim. Madam Sim is one of our residents here. She, at this point, when we first met her in I met her in 2016, and back then she was about 74. Prior to that, the 5 years, she's had multiple visits to our emergency department and also hospital admission. So in total, we counted it's about 18 visits altogether, and that was a healthcare course. Even though our nurses went in quite early and was working with her, our home care nurses, the the emergency visits didn't stop. So she continued to come in until in 2019, when our wellness kampung was ready, the nurse then introduced her to the community there. And really that's when we started to see her thrive. So this is Madam Sim's network. So she's connected with a lot of other seniors in the community. So it was through Wellness Kampung that she got to know her best buddy, Madam Selina. So Selina is actually almost 10 years older than Madam Sim, but they became very good friends because they both enjoyed the same 7 p.m. Channel 8 TV show, and they had a lot to talk about the plot holes, about favorite characters, and they bonded really, and they would actually started. So Selina started to go to Madam Sim's house in the evenings at 7 p.m. just to watch TV together. It was through there also she learned about some of the difficulties that Madam Sim had at home. So she was fearful of fall. She always had a fainting spell, and she had difficulties keeping up with her medication. So she would actually give some of this feedback to our community nurse and say, you know, I think she really cannot manage 13 medications, so we need to help her with that. And Madam Sim also had a recurring fainting spells. So Selina, as her buddy, right, what she would do is she will always carry the Feng Yu in her little bag, and that's for her friend, it's not for herself. Together, they're also connected to Madam Lee. So Madam Lee volunteers at the center. So she cuts hair for Madam Sim and Selina as well. They all visit our comm nurse, Nurse Lee. So Nurse Lee knows all three of them. Nurse Lee then collaborates with our SharePod team to make sure that those who are a little bit more frail knows about the SharePod program and knows can come down and join us for the program regularly. So I think as you see how it all expands, the connection that we talk about, I thought Madam Sim's case was really quite important. It was not so much to just connect residents to our staff or even our programs, but is to connect them with one another, because that is where you will see the exponential growth. That is where you will see expansion of resources that you never think that would be possible. It doesn't need to be created by the staff, it's created by residents themselves. And as they are creating this, they get stronger and they will get healthier. So finally, before we leave, I think Holly and I have a video to share with you. Fadil, if you can help us to play.
我以前是住山大，跟老爸一起做。我从小不会读书啦，我是种菜的。现在我退休了，不用做了，这样啦，来765这里帮忙做这个义工的啦，种一点点菜啦，摊的菜啦，菜心芥兰啦，这样，我的花啦、木瓜啦，帮忙这样浇水。下肥料了，没有什么了。
Tan is a retired farmer. He joined our Kampung Wellness a few months ago. He's very experienced in gardening. After time for harvest, he will tell me it's time to harvest the vegetable, then ask me to cook for the resident. I feel that Uncle Tan is very helpful. He knows what the resident like, healthy food. So he plant the vegetable without adding any insecticide. They enjoy very much what Uncle Tan plant. They enjoy.
Angeline and I started tri-generational home care, or Tri-Gen for short, in 2014. But what we noticed as medical students, while rotating through the hospitals, we noticed that patients with tightly knit family tend to do better. We always wondered why, and finally it dawned on us that perhaps they did better because their family members will advocate and care for them throughout the journey. Tri-Gen was started with the hope of bringing together the elderly, the young adults, as well as the students together as one family to promote intergenerational learning and care, and as well as together they can care for those who are vulnerable within our society.
Tri-Gen is made up of student volunteers from medicine, nursing, social work and pharmacy, as well as community partners from Yishun Health and Northwest CDC. Students will be organized in small teams with university students, and subsequently they will make fortnightly home visits over a period of 1 year. To equip the secondary school students, we organize interactive sessions with them so that they will be able to learn caregiving skills and problem-solving skills. And through this, we hope that they will be able to understand the needs and the difficulties of the seniors.
I first joined Tri-Gen when I was in year 1. That was when I first met Angeline and Kennedy. They left a really deep impression on me because they were very engaging, and also at the same time they were very nurturing. That attracted me to join Tri-Gen.
我听说这个养生村有老师来教导这些车百纳贝啊。不过这一张是往生贝，往生贝就是说以后我们最后一天走的时候，留下来给你的家属看你要送给谁啦。还有这个图呢，是老师带我们去，就是这边附近的庙拍的。我们坐在这里拍，代表以后我们要走的那一天是怎么样的。这样我就选择这样，代表我那天要走的时候，希望能像现在这样很安详安详的走，没有痛苦，所以也不会给家人拖累。这样，我们每个人都有自己的想法，字也不一样，设计都不一样。
我家里以前有车衣的我就拿来剪咯，自己剪就自己车咯，车就拿来给老师看咯。我跟老师讲我种花，他就跟我印出来，叫我缝下去咯。花开富贵就是给女儿他们、儿子他们高高兴兴咯，还有平平安安，出入什么都每天都是平平安安啦。
有的人好像觉得，哎呦，做这种事情很不吉利，什么不用怕嘛。他们有的时候说什么笨蛋，说哎呀，做了这种哪里好了什么了？我说他们很勇敢。
Thank you, Yvonne and Hoylin, for this wonderful sharing, and for the video. It's really very heartwarming. So we do have quite a few questions posted by our attendees. So the first question would be, do other areas around Singapore have similar healthcare events or organizers such as similar to Yishun Health?
I think across NHG, so this is for Central, Yishun Health, and also Woodlands Health, our new colleagues further up north. I think there's a lot of alignment in terms of our strategy. While there are some slight differences because each of our communities is different. And I think like the 2S2C model that Hoylin shared with everyone earlier, that's quite a consistent trend across all three zones in NHG.
Thank you, Yvonne. Another question is there a way to volunteer for the TriGen?
I think if you are with NUS, I think you can reach out to them. So this is the pharmacy, social work, medical and nursing students. I think with the CDCs, so with Northwest CDC, you can also reach out to them. But also I wanted to just remind, there are a lot of other groups that you can reach out and volunteer as well. So if you need a few resources, you can just maybe get in touch with us later. We'll be quite happy to direct you.
Thank you, Yvonne. Next question is, what challenges are we facing currently and going to expect in the future? And how can we overcome it?
Hoi Ling, you chip in on this, but maybe I'll get started first. I think the way people are aging is going to be very different. So we're already seeing a very different behavior from our pioneer generation, and with comparing them with our medical generation, and with the baby boomers, those who are born after 1965. So I think for us as a healthcare system, there is also a need for us to adapt the way we work with residents and patients. I think, like we said throughout the presentation, right, there is a need to evolve the way we approach healthcare from a deficit model to one that is a bit more strength-based. It's very scary to be ill. But it's important to remember that no one wants to be. Yeah. So while someone is ill, don't ask them to just focus on the illness bit. But there are still things that we all can still do. Older people can still do. Just take the example of the video, the last story that we heard from Wei Kun and Auntie Guning, right? They wanted to talk about end of life with their children. They might be old, and a lot of people are afraid to broach the topic with them. But they wanted to start because they know that it's a difficult conversation, but they're willing to brave it. So sometimes it's meeting people where they are already at, and letting go some of maybe stereotypes or maybe even stigma that is so ingrained in all of us.
Yeah, I would like to add on. What are the current challenges that we are facing is definitely we know that MOH are also push beyond these three beyond, like beyond healthcare to health and beyond hospital to community. Yeah, what we are currently doing is we are really pushing on to this beyond hospital to community. That's why the important for us to continue this one of these strategy to sustain the quality of healthcare, because the population is really aging. Yeah, we really need to prepare our whole healthcare system. Yeah, that's why there is an example of this war against diabetic. Yeah, our AdMC colleagues are also participating actively in this approach. And our community nursing currently are also going to upstream to do more preventive care. Like we will actively screen residents with 40 years old, whether they have diabetic, whether they have seek their treatment for their chronic disease management. And how do we overcome it? I think every organization and every cluster are working on it also actively to plan our strategy. So each of us in the healthcare system are very important. As just now we heard from inpatient setting, outpatient setting, and community setting. So with the joint effort, that's why Yvonne also mentioned about now NHG are focusing on this one care plan. So hopefully that the patient journey will go very smoothly in each touch point. And I also noted there is one question talk about treatment adherence, because this is a very common, Johnson will know, Johnson can add on later, common problem that our elderly residents will face, especially with their chronic disease management. Yeah, then how are we teaching our team to go about this approach? Because you will always face them not willing in the beginning. So now we are focusing to talk about a lot of building relationship, to talk to them. And we, over our Yishun Health, we also using this, just like Yvonne mentioned, PCSP approach. It's a personalized care and support planning approach. In this approach, we come up with a very systematic framework. We talk about preparation. For example, I just bring a case scenario. Example, a resident with diabetic. We educate them to put on this Libre sensor insertion. It's a sensor that will monitor the sugar level for the next 2 weeks. So during the journey, right, we will educate the resident on how to monitor how to scan their own sugar level. So after 2 weeks, we will give them a report. Now we will educate them on this report, how to interpret. We will teach them how to interpret, like how to relate your diet and your sugar level before they go to AdMC to see a doctor. So that is a preparation part that we are focused a lot on. And second part is talk about conversation. We now teach our nurses to talk about meaningful conversation, meaning that the core skill is very important, the motivational interviewing skill. We focus to teach them on open question, affirmation, reflection, and summarization. There's another, you all can Google and look for it. What is motivational interviewing skill? This skill is very important if as a nurse or even as a connector. Then we also need to teach our nurses on the attitude. We need to be genuine, to be able to speak clearly and kindly to the resident. We don't treat the resident like, I am a nurse, you are the patient. We need to treat them as equal. Like we need to respect them. Whatever they say, we need to respect them and respond to them that we hear you. That's why the affirmation is very important. And from there, right, it's very easy for us to build relationship after that. So the first few interactions is very important. So that is a question can address the adherent part. But it's not easy. We normally need to work along with the patient, maybe at least 2-3 home visit setting in order to gain the trust.
Thank you so much, Yvonne and Hoylin, for your sharing. It was really very insightful, and thank you for your time. We'll proceed on to the last segment, sharing by Ms. Sabrina Au from Tan Tock Seng Hospital. So she'll be sharing more on the Integrated Care Hub, ICH for short. Sabrina, please.
Hi, my name is Sabrina. And I'm an occupational therapist working in Tan Tock Seng Hospital and also very involved in the planning of the Integrated Care Hub. So today I would like to share with you some of the very exciting upcoming stuff about what this ICH is about, where we use very advanced rehab techniques and care facilities to help our patients reintegrate back into the community to have meaningful participation. Next slide, please. So as you can see over here, there's a picture of our health city novena. So if you were to see in this picture, you will be able to see Tan Tock Seng Hospital. And within Tan Tock Seng Hospital and also in this picture, you will be able to see the other healthcare facilities. And actually our Integrated Care Hub is part of this health city novena. Would you be able to click on the slide? So you can see actually the other buildings, healthcare related buildings. These are actually facilities that are in the Health City Novena, and we have our Integrated Care Hub as the upcoming new building on the top left hand side, as you can see over here. Next slide, please. Next slide. Okay, so what is this Integrated Care Hub, and why do we need Integrated Care Hub? So as you can see over here, when our patients get admitted to Tan Tock Seng Hospital, they come in for acute care. So they may be, coming here to resolve certain medical issues. And we also have outpatient services and as well as emergency services. So when our patients actually get a bit more medically stable, this is when patients would need to undergo rehabilitation, and also some of them may need some subacute care before they can actually go back home. So why do we need this ICH? It is actually to support this higher proportion of elderly in central health of Singapore. So in Tan Tock Seng Hospital is one part of central health Singapore region. And it is also to have a seamless care continuum so that when patients go from the acute ward and then before going home, they can actually practice the skills that's needed for them to be able to manage to cope back at home. So it also enables the right siting of care as well, where this rehab facility, ICH, will be a place for our patients to receive rehabilitation. And the proximity with Tan Tock Seng Hospital also ease the anxiety of patients in transfer, that they are not actually transferring to a building or facility that is, quite far away from Tan Tock Seng Hospital, where, if let's say they became not well, they can actually transfer back to the main Tan Tock Seng Hospital. And also, it also helps with caregivers, when they come and visit and all that, they know that ICH is just next door to Tan Tock Seng. Next slide, please. So what is this ICH? So the vision of this ICH is really to optimize cost-effective functional recovery, where patients receive this rehabilitation and a smooth transition back into the community, that the patients, after if they need to learn certain skills, they can actually go there for intermediate care for patients in the central regional health system. So we hope to enable patients to have early return to daily functions in their life and also active aging, so that they can be empowered to actively participate in self-management skills, to be able to cope, with the challenges, if they are to go back home. And we also partner with community to provide sustainable healthcare services also. Yeah, next slide, please. So how does this link, with our Tan Tock Seng Hospital? So ICH will function as a crucial bridge that's linking acute hospital and community care, and also help to optimize our patients' recovery and independence to prepare them back at home and also in the community. Because when we look at the patients, we do not just look at patients like, oh, you have to go back home, but patients have got other roles, such as, they may need to go back to work. They may need to go back to school as a student. They may need to go back to their roles of a homemaker. They may need to go back to their existing, roles that they need to be able to do. Yeah. So from the acute hospital and inpatient, then they can transfer to this ICH for rehabilitation or subacute care, and then they transit back home and community. Next slide, please. So what are some of the facilities? So I'm going to just show you some pictures. So this, because the building, ICH building is still in construction, but I would just like to show you some exciting photos of artist impressions. Yeah. So in ICH, you will have this, in this building, you have public areas. So this is level 1 of the atrium, where we will also have got a food court and also retail home care, where patients and family members, if our therapist says that, oh, this patient may need certain equipment and all that, so they can actually go down to see, what is this equipment, and then plan, to plan for the future. If let's say patient's going to be discharged and need certain equipment, they can actually go there and purchase them. Next slide. Then we also have, as an outpatient facility, a living resource studio, where patients can actually, come here for therapy. Very specifically, we have a new feature of an outdoor mobility circuit. So I believe some of us may have seen patients who are riding on wheelchairs and also motorized devices, where patients, before they use these devices, it will be better for them to undergo this training on how to use the devices safely in the community. So this mobility circuit will be able to give them that so-called a safe environment for them to practice the skills that's needed to use the devices or the wheelchairs. Then we will also have a studio flat, like a daily activity, like a home, so-called something like a home, so that patients can practice their daily activities in that home-like environment. Yeah, so this living resource studio, we hope that we can provide the patients and also our caregivers with information and also assessment and advice on the various assistive devices and technologies that the patients may require, and also for to give training to the caregivers on how to safely take care of the patients back at home. Yeah, so it also act as an educational platform for visitors as well. And we hope that visitors can learn and understand about disability, health, wellness related topics like energy conservation and fall prevention. So in this living resource studio, we even have a donated bus that will be placed in part of the mobility circuit for training. Yeah, so so that the patients can practice going up and down the bus. Be it if they were to walk, or if they are using mobility devices such as a motorized scooter or motorized wheelchair, then they can practice on a very much close to a realistic kind of simulation or practical session first before they were to really go out in the community. Next slide, please. Then in this ICH, one of the levels, level 2, they will have adaptive sports court. Yeah, so I think some of the patients who have got physical challenges, they are still quite keen, very keen, to actually do sports. So this sports court will give them the facility, the opportunity to actually do all these sports. So it will be fairly big, like almost half a basketball court size. And also so where our sports integration program can take place, and it will involve volunteers also to interact with patients and also previous patients, like the support group, and so that patients can actually participate in activities like table tennis, fitness, yoga, and etc. Next slide, please. So the pictures of a ward. So in total, there will be about 500 beds, 508 beds. These are just some artist impression of how the ward will look like. So we will have 5-bed cubicles and even private rooms as well. Next slide, please. And in each ward, we will also have got a gym where patients can be assisted into this area for more intensive therapy, where our therapy equipment will be kept and patients will receive their rehabilitation there as an inpatient. And in the wards, we will also have got areas like activity areas where we will try to simulate as home-like as possible. There'll be areas whereby patients get the opportunity to practice on how to help themselves back at home. Like for example, maybe boiling water, making drinks, and etc. Yeah, so this will be the activity area. So where we give patients opportunities to practice their daily activities in the ward setting. Next slide, please. Yeah, so in the ward, to actually help manage patients who had a traumatic brain injury, those of us who are familiar, some of the patients may present with certain challenges like behavioral issues. So this brain injury monitoring room will be a facility that can nurse patients and take care of patients safely because they have got certain safety features such as like padded walls and flooring without the need of physically restraining patients. Yeah. Okay, next slide. We also do have a dementia care ward as well in ICH. And this dementia care ward is carefully planned, and the environment is planned in such a way that we can practice dementia-friendly design, where some of the features for safety at the ward will involve, we will try to make the ward as domestic and home-like as possible. If you are familiar with looking after patients with dementia, you will know sometimes they may get easily confused if they are in an unfamiliar environment. So we want them to feel, as at home as much as possible. and give them space to participate in also meaningful activities. Things like maybe before coming to the hospital, they may have certain activities that they have been doing. Like, some of them may like to read newspapers and all that. So we try to create that space in the ward for them, for this dementia ward. And also we want to keep them safe by not restraining them and things like that. But we will want to do it with creating or designing a safe wandering space within the cubicle, or for some other patients who can wander out the cubicle, to have a safe wandering space outside cubicle, and also to have good signage as well within the ward, so that the patients will know, okay, where is the toilet, where are places that they can access things that they need at the ward, using objects rather than colors for orientation. What I mean, like if you want to guide them to the toilet, maybe not just the female or the male sign, but maybe a picture of the toilet. Yeah, to enhance also visual accessibility, that if we want them to go to the toilet or go to a certain area, we try to help them be able to see all those things, all those places. And also, let's say if we want to keep certain dangerous items from them, like for example, sharp objects, then we try to keep them away. And also in this work, we try to control the stimulus as well. And also having adequate lighting in the daytime, and also maybe a dimmer lighting at night, so that you can help these patients be able to sleep well. Yeah, aid in the sleep cycle. Yeah, so that they know, okay, now is the daytime and now is nighttime, and then okay, it's time to sleep, and daytime is a time for you to come and do activities. Next slide, please. Right, so in this ICH, what kind of services will they receive? They receive allied health services. So we have a whole team of allied health professionals who will be working there. We have our physiotherapists, occupational therapists like myself, speech therapists, dietitian, medical social worker, psychologists, podiatrists, our P&O colleague as well. Next slide, please. So some examples of therapy programs that we have in ICH. We have our very exciting robotics assisted gait retraining programs. We have gait retraining. We will also have low vision rehab, assistive technology, where we may use certain technology, even for example iPad or something like that, to do therapy. We have also horticultural therapy, where patients participate in meaningful activity like gardening and all these activities, and encourage them to practice their mobility back at home. Okay, and also returning to work or school services, also help to manage spasticity for patients who need them, like casting and splinting. We have got sitting clinics, sitting prescription for patients who require very more specialized wheelchairs. Yeah, when we also have got group therapy where patients can actually come together and do activities as with other patients. Next slide, please. So in this slide, I just want to show you like a trial that we have been doing with our patients in the wards. There's a picture of a horticultural therapy corner where our patients come and do gardening. Yeah, so but besides gardening, I mean, of course, they also do certain other activities using the products that they have grown. Yeah, so this is a very beautiful picture of how this horticultural therapy corner has evolved, and then we have been bearing fruits. As you can see here, you see a picture of cucumber and also lady's fingers. So patients take care of the plants, they water the plants, and then harvesting as well. Next slide, please. Last but not least, this is one of the last few slides. Yeah, so just want to share, stories of working in hospital, acute hospital, and also even ICH. What are some of the challenges? as an OT. So these are some comments that we have gathered also from some of our colleagues who join the department. So when we come to work, in this kind of setting, I think we use a lot of assessments. We want to find out what patients can do and what patients cannot do. Yeah, and then in a ward-based environment, many of us have to walk a lot because we have to go from patient to patient to provide therapy. And we also need to support our patients to go back home. So we don't just think about patients doing therapy in the ward, but we need to think about how to do therapy so that we can prepare them to go back home. Are there any services they would need to support them to be at home? Safe manual handling in terms of like transferring, we need to be able to assist patients, from the bed to the wheelchair, and some of them have physical challenges. So we need to know how to safely assist them. And there could be certain medical conditions that we sometimes, we have to keep learning, what are these medical conditions. And sometimes we may also meet with situations where our clients may become unwell and then they may deteriorate. Okay, next, what is the client talking about is a very common situation that we encounter, where clients may be language barrier, we may not know what they are talking about. And so therefore, when we are seeing the patients, we have to really ask and probe more so that we kind of understand what they're trying to say, what are the certain challenges that they foresee themselves may encounter when they go back home. And we may have to also manage expectations of family members, like, is the patient able to walk, if the patient able to go back home and things like that, or wanting certain equipment. Of course, clients sometimes, especially on a rainy day, where they want to sleep in, then we come and do therapy. So these are some challenges that we do encounter, as a therapist at the ward. Next slide, please. So besides challenges, there are many more other joys that we encounter. So we work closely together in a team where we work with doctors, nurses, and also our other allied health colleagues. There's teamwork among our colleagues as well. So it's not just a solo one-man show to take care of a patient, but it actually takes a whole village. So also we get mentoring as well for our colleagues who just joined us. We have got seniors, we have got supervisors who will be there to support them if they have questions. These supervisors or seniors will be able to guide them. And it's actually very satisfying to see patients improve functionally. That means they are able to return home well supported. And sometimes, if we were a new staff, a new therapist, we find that we learn a lot in a very short time working in a hospital or in an ICH setting. So in Singapore, to be able to practice as an occupational therapist, physiotherapist, we need to be registered under Allied Health Professional Council. We need to be registered. So for us to do that, over here in our organization, we do have a supervisory framework to help our new staff. And so they are not just thrown, to see the patients themselves, but there's a supervisory framework where we support them with this supervision. And we'll also learn to internalize and use our therapy models very well, like see a patient or the clients, not just as a medical condition or disability, but we see them as a holistic person. What is the challenges? What do they want to do? And etc. And many of us, as we work, we actually mature as a person as well because of the various experiences also that we learn from our patients, what are the life experiences, and also improving on communication skills as well. In fact, myself, I may not be very good in dialects, but actually when I come to work, when I actually work in a hospital and I interact with our elderly patients, this is where actually I even pick up a few dialect language. So this is one of the joys that we encounter. I think this is my last slide. Okay, next slide. Right, so thank you very much.
Hi, Sabrina. Thank you so much for your sharing. It was really very insightful. So thank you, speakers, for all your insightful sharing. We have just come to the end of the session and hope that you have benefited from this sharing. If you have enjoyed this session, please take a few seconds to rate this program by the number of stars as you can see below this screen. So our next session is Dare to Care, a call to our future healthcare scholars, will be happening tomorrow, 21st February, from 1 p.m. to 5 p.m. Join the Healthcare Scholarships team for this information session to learn more about making a difference with healthcare scholarships. In addition to an overview of the scholarship schemes offered, you will also hear from our occupational therapy, physiotherapy, nursing, and admin scholar ambassadors. And there will also be sessions with our healthcare clusters, National Healthcare Group, National University Health System, SingHealth, and Agency for Integrated Care. So we look forward to seeing you in all our upcoming sessions. Go on and have fun as you learn to dare to care in our online webinars and virtual activities. Thank you so much. Have a great weekend ahead.